Good evening. Thank you for attending our Ahead of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. There are a few housekeeping items that we'd like to review before we get started. During the presentation, all participants are able to type in questions into the chat portion of the Zoom connection. We'll be addressing those questions if time allows at the end of the lecture. Participants are not able to speak during the conference, but again, we encourage feedback through that chat option. Tonight, we are excited to welcome Dr. John Lister, who will be speaking about the treatment options for patients with blood cancer. Dr. Lister is chief of the Division of Hematology and Cellular Therapy of the Allegheny Health Network Cancer Institute. He is an experienced transplant physician who participated in his first bone marrow transplant in 1979. Since that time, he has been involved in over 1,400 transplants. He has contributed to original and groundbreaking clinical studies, including that which led to the approval of the FDA of rituximab for the treatment of lymphoma. He lists 80 peer-reviewed publications and more than 200 abstracts presented at local, national, and international meetings. The cellular transplantation program of the Cancer Institute performs autologous, allogeneic, related and unrelated transplantation from matched, mismatched, and haploidentical donors, and umbilical cord blood transplantation. The program also serves a beginning portfolio of clinical investigation in CAR T-cell and TIL therapy. Dr. Lister received his initial exposure to marrow transplantation as a fellow at McGill University in Montreal, and subsequently further training at the Fred Hutchinson Cancer Research Center in Seattle. Thereafter, as a Terry Fox Fellow of the National Cancer Institute of Canada, he received additional laboratory training in marrow transplantation and immunology at the Ontario Cancer Institute, Princess Margaret Hospital at the University of Toronto. He returned to McGill and actively participated in marrow transplantation for the next 5 years before accepting a position in the Division of Hematology and Bone Marrow Transplantation at the University of Pittsburgh. In 1997, he joined the faculty at the Western Pennsylvania Hospital and has remained on staff as a transplant physician, clinical researcher, and laboratory investigator. Dr. Lister is professor of medicine at Drexel University College of Medicine and has served on numerous scientific and administrative committees, including the Lymphoma Committee of the CIBMTR, a member of the Board of Trustees of the Leukemia and Lymphoma Society, and a member of the Immune Effector Cell Task Force of the Foundation for the Accreditation of Cellular Therapy. In 2012, he was recipient of the Golden Headed Cane Award, which is given to a member of the West Penn Hospital medical staff who best exemplifies the qualities of a physician, teacher, and investigator. Welcome, Dr. Lister.
Thank you, Crystal. And good evening, everybody. As we start this talk, this is an exciting area, new treatment options for people with blood cancer. When I started out this talk, I thought that I might be able to encompass everything that we do, but I'm going to have to limit my remarks to lymphoid cancer this evening. Otherwise, we'll be here into the wee hours of the morning. Everything that we'll talk about here is applicable in its general terms to the other forms of blood cancers. And I would encourage you, if there are other lectures coming on regarding myeloid malignancy, such as acute myelogenous leukemia, myelodysplasia, to attend a lecture by one of our experts in that area. Likewise, for those among you who might have multiple myeloma or amyloidosis, we would have another talk in that area to tickle your fancy, perhaps. But let's start by trying to divide up what new processes or new therapeutics are available for patients with lymphoid cancer. And they broadly are broken down into 4 categories. So there is targeted therapy. There are immunoconjugates and engineered antibodies. There are bispecific T/NK cell engagers. And of course, there is CAR T-cell therapy. So let's start with targeted therapy and take for this area the example of Bruton's tyrosine kinase inhibitors, or BTKIs. There are 4 of these that are approved for use in the United States. The first one that was approved was ibrutinib. Subsequently, acalabrutinib and zanubrutinib were approved, and most recently, pirtobrutinib was approved and brought to market. So what do these agents actually do? This is a cartoon that depicts a malignant B cell. At the top, you will see various things that stick off the cell surface. And I would draw your attention to something called BCR. That's short for B cell receptor. I would also draw your attention to 2 molecules that sit beside it, CD79 alpha or A and CD79 beta or B. These molecules extend through the cell surface into the cytoplasm, where they interact with other forms of protein to eventually activate downstream factors that bind to the DNA in the nucleus. And this results in the cells being able to divide, make more of themselves. They survive, and they can survive attack by various things because of this. So as you can see here then, a malignant B cell and a normal B cell would in fact be reliant upon continual signaling from the Bruton's tyrosine kinase. And it is this class of drugs that in fact inhibit the BTK, prevent the downstream activation of these transcription factors, NF-kappa B and ERK, and therefore make the cell vulnerable to undergoing its own internal death process. So it's a targeted form of therapy, and the target is the Bruton's tyrosine kinase. So what's the difference between these 4? Well, ibrutinib being the first one has been eclipsed by the other 3. Acalabrutinib and zanubrutinib are clearly less toxic than ibrutinib, and particularly there are specific toxic events that occur in the heart, such as an irregular heart rhythm, that are less frequently seen with acalabrutinib and zanubrutinib. So they are actually preferred to treat the target diseases being chronic lymphocytic leukemia, mantle cell lymphoma, and other forms of B-cell malignancy. Pirtobrutinib, on the other hand, is a more effective next generation compound that differs in the way it inhibits the BTK. The other 3 bind by a covalent bond to the BTK, and that, although it's hard to describe, that in fact makes the BTK inactive. However, the drugs can be consumed relatively quickly, even when they're taken, twice a day, and therefore the cell can make new molecules of Bruton tyrosine kinase, BTK, and circumvent the normal inhibition. Pirtobrutinib, on the other hand, does not bind covalently, but sticks to the BTK and makes it inactive. And because of this, it can distribute over the whole mass of BTK molecules in a cell, and it appears to provide coverage of this target so that it remains inactive in the cell. And in fact, clinical studies have shown that pirtobrutinib in fact can provide response in patients who have CLL or mantle cell lymphoma that is not responsive to the other 3 BTKIs. In addition, pirtobrutinib is very specific. It lacks the off-target inhibition of other kinases. Kinases are general protein molecules within the cell that are responsible for transmitting a lot of the signals from the outside to the inside of the cell. And if there are off-target effects, one can experience side effects because of this. Let's move on to immunoconjugates. And For this, we'll take the most recently approved one in June of 2019, polatuzumab. So this is a unique molecule, an antibody drug conjugate. So as I mentioned before, it is a monoclonal antibody against CD79B that was next to the B cell receptor on the surface of the malignant B cell. But it is conjugated to a powerful, potent antimicrotubule inhibitor, monomethyl auristatin E. And what happens in this situation is that the polatuzumab sticks to the surface of the cell. The cell then internalizes the whole complex, and once internalized, it cleaves off the protein from the monomethyl auristatin E. The monomethyl auristatin E, once inside the cell, is a potent toxin, and it kills the cell specifically. So if we look at where this might fit in clinical treatment, one of the things we've been trying to do in the treatment of lymphoid malignancy is to find something to replace a regimen called R-CHOP. I'm old enough to remember when the standard was just CHOP. There was nothing that seemed to increase the effectiveness of standard chemotherapy beyond CHOP itself. But when rituximab was approved, it in fact turned out to be a superior regimen and became the de facto standard for the treatment of B-cell malignancy. When compared in a clinical trial, and I'm going to just digress momentarily to describe what these curves actually mean. So you will notice that there are two curves in each of these cartoons. One is labeled R-CHOP for those patients who received R-CHOP, and one is labeled POLA-RCHP for those that received polatuzumab, R, and everything but the O in CHOP. So POLA-R replaces the O in CHOP in this situation. Each of these curves is punctuated by little vertical lines. That represents one patient. Each of these lines represents one patient that is analyzed at a certain time after finishing the treatment. And you can see here in panels A, B, and C that there appears to be a superior outcome associated with POLA-RCHP than with R-CHOP. And the way we're able to calculate this is to look at something called a hazard ratio. And when that hazard ratio is less than 1, it says to us that statistically we're confident that the top curve represents a better outcome than the bottom curve. Usually we represent that with a p value, and that p value here is 0.02. If it's less than or equal to 0.05, we tend to consider the differences to be statistically significant and also most of the time clinically significant. Because we're able to treat patients who fail either one of these regimens with other forms of therapy, there is not a difference in the overall survival, and you can see that in panel D. And you'll notice that at 3 years or more after treatment, more than 80% of people are still alive, even though they may have had return of their disease at some point before that. And in this hazard ratio, you can see it's 0.94, and it encompasses an interval around 1, which tells you that it's not going to be statistically significant. And the p-value, of course, is not less than 0.05, it's 0.75. So there's no difference in overall survival whether you got one regimen or the other. It would just take longer for the disease to eventually return if it was going to do so. So we watch with interest as what's going to happen in longer follow-up. What will happen when patients are out 5, 7, 10 years after therapy? Will these curves be different with respect to overall survival? If that is the case, then POLA-RCHP would be the de facto standard for the treatment of diffuse large B-cell lymphoma. Another immunoconjugate that was recently approved is a drug called tafasitamab. And the CXIX, I can't explain that. That's just too technical. This is used in combination with an oral drug, lenalidomide, and was approved in July of 2020 on the basis of a phase 2 study. In other words, just treating patients on the drug alone. So 81 patients greater than 18 years of age with diffuse large B-cell lymphoma who had seen 1 to 3 prior lines of chemotherapy, and they all included at least one line with an anti-CD20 antibody as is standard. They also had to be ineligible for high-dose chemotherapy and autologous stem cell transplantation. This drug is actually interesting because it has multiple ways in which it can kill malignant B cells. The drug is represented by this cartoon sort of finger, hand with 2 fingers on it at the top, and it binds by that affinity matured CD19 binding site to the surface of the malignant B cell, as you can see in the cartoon to the right. Once it does that, it can actually trigger the malignant B cell's death just by binding to CD19. But it can also result in the death of the malignant B cell by recruiting in other components of your natural immune system. On the left, it can recruit natural killer cells, which are part of your immune system and circulate in your blood. And when the natural killer cell sees the other end of the antibody, it realizes that it is in proximity to a malignant cell and releases various substances that will kill the malignant cell. And we refer to this as enhanced antibody-dependent cellular cytotoxicity. Likewise, on the right, another cell called a macrophage, which has as its principal function basically gobbling things up, which we like to attach the name phagocytosis to. So you can see here that the macrophage may find the malignant B cell somewhat delicious and try to eat it. And that we term enhanced antibody-dependent cellular phagocytosis. So this is how this particular antibody tafasitamab works. 3 ways in which it can kill a malignant cell. In the L-MIND study, which was the one that resulted in registration here, you can see that the time for half of the patients who received the drug to have progression of their disease was about a year. So it was a good bridge to prior therapy. Interestingly, the rate at which the disease would come back in the subsequent year was far less than it was in the first year. So there are patients who have received this drug who have had stable and long-lived multi-year remissions from its administration. So this represents a completely new way of treating patients. Another one of the most recently approved of these agents is something called loncastuximab tesirine. Again, it is an anti-CD19 antibody, and it is conjugated to a cytotoxic alkylating agent, piece of chemotherapy. This drug was tested, this drug is represented in this cartoon. You can see that the antibody is very much like tafasitamab, a hand with 2 fingers sticking up. But attached to that is this piece of chemotherapy on the right that is linked to the antibody itself. So it doesn't interfere with the function of the antibody. It still sticks to CD19. But once it sticks to CD19, CD19, in addition to the antibody with the chemotherapy piece attached to it, are internalized into the cell. Once inside the cell, the linker component is cleaved and the chemotherapy floats freely and does its damage inside the malignant B cell. There was a pivotal study termed LOTUS-2 in patients with relapsed and refractory diffuse large B-cell lymphoma that showed an overall response rate of about 48%, and about half of those patients achieved a complete remission. These responses were somewhat durable, and the safety profile showed that it was tolerable and could be safely administered to patients who were quite ill. So another way that we are able to target malignancy and perhaps preserve our normal functioning immune system. Now, to move on to bispecific T-NK cell engagers, we have two specific examples here that are worth mentioning. The first is mosunetuzumab, which is a bispecific agent. Both of these agents have two business ends. One end will stick to something called CD20. CD20 is on the surface of all malignant B cells, and also normal B cells for that matter. The other end will stick to T cells, so normal T cells. So you put a T cell up against a malignant cell, and the T cell will activate its ability to kill the cell it's next to. And you will use, again, your own immune system to kill the malignant portion, the malignant B cell or lymphoma cell. So this was the first one that was approved. It was approved for follicular lymphoma just because of the way the clinical trial was run. At the same time, and just this month, glofitamab was approved for use in patients with relapsed or refractory diffuse large B-cell lymphoma, or large B-cell lymphoma that arose from follicular lymphoma. And this we refer to as transformed follicular lymphoma, after 2 or more lines of therapy. And again, what we see here is quite inviting. This is unfortunately reproduced as I would have wished. This is for mosunetuzumab, and it shows, much as we had discussed for the first series of survival curves, that the survival from follicular lymphoma is very, very adequate. But follicular lymphoma tends to recur. This is not a cure for follicular lymphoma, but it could certainly be used as a bridge to other therapy without being highly toxic to the patient, like as is chemotherapy. Likewise with glofitamab, and this was published in the New England Journal, and I'm happy to say that one of our staff one of our physicians is an author on this paper that resulted in the registration of this medication. You can see that in the bottom curve, the number of patients that remain free of progression of their disease dwindles away after 12 months or so. But again, this is an agent that could be used to bridge patients to other forms of therapy, like CAR T-cell therapy or allogeneic or autologous peripheral blood stem cell transplantation. The top curve just represents the percentage of patients with a complete response. So in the final part of our presentation, we'll touch upon CAR T-cell therapy, which is a miraculously new form of therapy, which takes cells out of the patient and genetically modifies them to express a receptor on their surface, so that the CAR T-cell, the T-cell, will stick to the malignant cells. And as I've said before, when they stick to the malignant cells, they do the damage to the malignant cells and kill them. If you'll look here, the first agent was approved was tisagenlecleucel on August 30th, 2017, and then quickly thereafter, axicabtagene ciloleucel was approved on October 18, 2017. These agents cover very similar indications, and their indications have been expanded since that time. Brexucabtagene is really just a repurposed axicabtagene, and another company got in on the act and created lisocabtagene. The differences between these are somewhat minor, but there are differences between them. Lysocabtagene might be less prone to cause the major side effects of CAR T cell therapy, that being cytokine release syndrome and immune effector cell associated neuropathic syndrome. Idacabtagene, which was approved on March 26, 2021, has had difficulty being produced for the marketplace. And this is the agent that targets something called BCMA and is used for the treatment of patients with multiple myeloma. So this is roughly the FDA approved landscape of CAR T cell therapy. At the Allegheny Health Network Cancer Institute in our division, we have a number of experimental forms of CAR T cell therapy, and I'll go over them in a little bit of detail here. One we have is called an allo CAR, which I refer to as a parked CAR. Another one is a CAR plus synthetic IL-15. That is a substance that makes T cells grow, and we call that an armored CAR. And we have another one coming in clinical trial that targets both CD19 and CD20. We'll call that 2 CARs. And then we have local in-house production of an anti-CD19 CAR. And I haven't come up with a name for it, but if anybody has a suggestion about a name for it, please text us or email us. So let's talk about an allo CAR. So this is a situation whereby a normal donor, not related to the person who will receive the product, donates T cells. Those T cells are then genetically modified to express an anti-CD19 receptor on their surface so they can stick to a lymphoma cell. And at the same time, they have a gene for a molecule termed CD52 knocked out, so they don't make CD52. And that's important because to get these cells to grow in a patient, as they are not from the usual, they're not from the patient themselves, you have to provide some immunosuppression, and that's done with an antibody against CD52. So this is sort of an off-the-shelf CAR that we're providing to patients. And these situations might be used for people who don't have enough cells in the peripheral blood that can be easily collected, or just the manufacturing process doesn't generate enough of them. So we could envision situations in the future whereby we might make cells from a patient and we don't have enough and we need to supplement them, then we could add these to it. So we look forward to the results of this clinical trial, which will take years to mature at this point. Another clinical trial that we have looks at adding a synthetic form of a molecule termed IL-15. IL stands for interleukin. This is one of the growth factors that make T cells happy. So in a situation whereby you're going to give a CAR T cell, whether that be an allo CAR, a normal CAR from the patient themselves, whether we make it in our own laboratory, we could add this IL-15 substance to try and enhance the effects of the CAR T cells. And this trial is ongoing at our institution. Another trial looks at a specific dual CAR in which the receptor that sticks off the surface of the cell not only recognizes CD19, but also CD20. So you can stick to both things at once. And there are some advantages to that. Sometimes CD19 is not expressed, and if that was the case, you would still have CD20 as a target. So we will be bringing this up in clinical trial within the next couple of months and hope to recruit patients to it. We also hope that this is something that in the long term is something that can be added to the armamentarium of cellular therapy. And lastly, we have our own clinical trial, which is a feasibility study of manufacturing chimeric antigen receptor T cell products for the treatment of B-cell lymphoma and B-lymphoblastic leukemia. This is being performed under what's called an investigational new drug application at our network. And of course, one has to jump through the hoops and report everything of the patients who are participating on this trial. We've been lucky that we've demonstrated that all the participants to date on this trial, we have been able to generate CAR T cells, and we've had some rather impressive responses. I think the difference between this and some of the other studies is simply that these cells don't have to be frozen for transport from a central facility. And we've noted that when we've given these cells in the fresh state, they appear to be very active from the get-go. Often we see some of the side effects of this type of therapy, such as cytokine release syndrome or CRS, very early on, within 12 hours or so after the cells are infused into the bloodstream. So we're hopeful that this might translate into a greater efficacy in the long term. This trial will be ongoing for a few years yet. So with that, I would conclude and just say that this will give you an example that there's a paradigm shift in the treatment of cancer, and that we hope that it will replace conventional chemotherapy, which results in nausea, vomiting, and hair loss as major side effects. These newer treatments appear to be much better tolerated, and we're learning ways of even improving upon that tolerance. And because of the ability to combine many of these therapies in the future, I think we are looking at a functional cure for many of these types of diseases. The only way that we have for proving that these agents are effective, of course, is clinical investigation, and the courageous patients that we have who participate on the clinical trials are the ones who pave the way for those that come after. And laboratory research, of course, guides us, and as we learn more about the biology of blood cancers, we will be better able to define their vulnerability and target that vulnerability to kill those cancers more effectively. So with that, I'll conclude and open it up to any questions that you might have. Thank you.
Thank you, Dr. Lister. We do have a couple questions. I'll just start at the top. One, my brother has blood cancer where his body produces too many red blood cells. Are there treatments?
So it's a little difficult to know. That is, we would believe to be a disease called polycythemia vera, or primary polycythemia. That is a disease that is usually defined by a specific genetic mutation in a gene called Janus kinase 2, or JAK2. And in that situation, yes, there are specific forms of therapy and targeted therapy. One drug that is used in that situation is a drug called ruxolitinib. And so, yes, and we believe that there are going to be other forms of therapy that can be used with this agent, and also other ones in clinical trial that are now being tested.
Okay, thank you, Dr. Lister. Here's another one. Can you discuss, no, I can't pronounce all of these like you did, brentuximab as a form of salvage therapy for relapsed classical Hodgkin's lymphoma, as opposed to stem cell therapy or CAR T therapy?
So that's, sorry, go ahead.
Go ahead. Also, can you discuss the related side effects of these options?
So brentuximab vedotin is another immunoconjugate. So it is an antibody with a piece of chemotherapy attached to it. And when it sticks to a Hodgkin's cell, the Hodgkin's cell internalizes that complex, cleaves off the chemotherapy, which then causes the death of the Hodgkin lymphoma cell. It's interesting because brentuximab targets something called CD30, which is not widely expressed on other tissues, so it is a relatively specific. Unfortunately, the major side effect of brentuximab is neuropathy, and that can be quite punishing, particularly in patients who have already developed neuropathy as a consequence of other forms of chemotherapy. But it has been shown that in follow-up to the initial trial that looked at patients who had relapsed, that there are some people who have achieved durable remissions lasting years now with that agent. So it might be a very effective agent in some people. If you can, I would add to that there is also evidence now that if you add checkpoint inhibitors to the treatment, and these are other monoclonal antibodies that cover up different molecules on the surface of the tumor cells and allow a more vigorous interaction with T cells, that you can also get very durable remissions in patients. So the combination of these checkpoint inhibitors, such as pembrolizumab or nivolumab, with brentuximab vedotin, is probably the most potent treatment that we have at this point for Hodgkin lymphoma. Where does CAR T cell therapy fit? CAR T cell therapy at this point is only experimental. There is no form of CAR T cell therapy that will target Hodgkin lymphoma. I would say that there's probably an exception to that, and that would be a specific form of non-classical Hodgkin lymphoma termed lymphoid nodular lymphocyte predominant Hodgkin lymphoma. However, we don't have a commercial CAR T product for that. Experimentally, there are anti-CD30 CARs that are being developed. We have a construct in the laboratory that we're testing now and may bring that into clinical trial in the future. When it comes to transplant, allogeneic transplant for autologous and allogeneic transplant still provides long-term survival, and it does have a multi-decade database that shows that these remissions are durable. With respect to brentuximab, we don't have that kind of evidence yet, but I would think that salvage with a checkpoint inhibitor and brentuximab is the most reasonable therapy that one can postulate. So I hope I've answered that question. A lot of talking.
Thank you. Okay, a couple more. They're just rolling in here now. I was diagnosed with CLL SLL 14 years ago. I saw Dr. Lister for a second opinion of diagnosis. I have not yet undergone treatment, but blood work is showing condition is worsening since then. Don't know if I have reached the point that treatment is needed, but if so, what type of treatment do you recommend?
So, that really highlights the situation, is that, we all probably have something, and CLL/SLL can be a very indolent disease. In other words, one that doesn't really bother you. It may bother your blood counts, but if it's not bothering you, is it really worth undergoing treatment? We have specific criteria that we use to decide whether somebody should receive therapy. And those criteria are basically related to, are the cells becoming so numerous that they're impacting normal organ function, such as there's so many cells in the bone marrow that you don't produce the normal cells of your blood. So are you anemic? Are your platelets low? Do you not have enough neutrophils, a type of white blood cell? Likewise, if you've got a tremendously huge spleen and it's pressing on your stomach and you can't eat, that's a reason to have therapy, particularly if you're losing weight. So when it comes to the first therapy that one should get for this is in a state of flux at this point, but certainly a BTKI should be there. So there were studies on the basis of giving a monoclonal antibody, obinutuzumab, with a BTKI like ibrutinib or acalabrutinib or probably zanubrutinib, that show that you could give therapy for a limited period of time, about a year, and then if you achieved a complete remission, you could stop therapy. In other trials, therapy was given until the disease progressed. So there are many patients who have been on these medications for many, many years. But now people have stopped them for various reasons. I have a gentleman who decided that he just didn't want to take it anymore, and it's got to be at least 7 or 8 years since he stopped the medication. He's still completely normal. So Yes, you have to have a good reason to take any medication to treat CLL/SLL, but the first go around should include a BTKI, and the preference would be a acalabrutinib or zanubrutinib.
Okay, thank you. Another question. I'm almost 70 years old and I was told that I am ineligible for bone marrow or stem cell transplant. Why would that be?
That's hitting very close to home here, as I'm only a year behind you, but so the eligibility for transplant depends on many factors. First, it really depends upon your physiological health. Age on its own is not a criterion that one uses to exclude people. Unless you get past 90, then it's been a pretty good run if you got past 90. And I don't think it may be worthwhile doing anything. Maybe that'll change in the future. I don't know. But age on its own is not a criterion. It's your physiological age. How are your lungs working? How is your heart working? How are your kidneys working? How is your liver working? Are you robust? Are you able to care for yourself? These types of things. How much therapy have you received? The other thing that has to enter into the equation are what sort of disease do you have? How many types of therapy have you had to this point? And is the disease still responding to the treatment? So there are many factors that enter. I would not just say that you're ineligible based upon your age, but those other factors have to be considered in making a wise recommendation to someone, and making sure that we think that there's at least a statistical chance that you will benefit from transplant, and that the transplant often has other problems associated with it. And if they occur, they can impair your health and your quality of life markedly. So one has to balance those things apart.
Okay, we have time for a couple more. I was successfully treated for DLBCL using R-CHOP in 2019. What should I be looking for in case it happens to come back?
So if you were treated in 2019, the chance that it's going to come back is getting to be small at this point. It's certainly going to be below 10% with diffuse large B-cell lymphoma. It's impossible to predict the future about what might happen in the future, but usually the types of things that people experience when the disease comes back are the same things that they experienced when they first had the disease. So the presence of painless swelling of the lymph nodes, other masses, it's very variable from one person to another. But I would say that if you're losing weight without trying, if you're experiencing fever and you're having drenching sweats, if your energy is just fading away, and if you can feel lumps under your arms or in your neck or groins, then that's evidence that you might have a recurrence of your initial diffuse large B-cell lymphoma. I should mention that, the longer people live past this, they may get other forms of disease too. And it's not without the realm of possibility, and we've certainly seen this, that you have one form of lymphoma and you get another form of lymphoma, completely unrelated to the first one. So anything is possible.
Okay, one more question. The Leukemia Society always talks about people seeing CII specialist, or maybe CLL. Are there doctors who specialize in CLL that are better than others?
Well, so I haven't really gone around and given examinations to my colleagues who do this. I can tell you what I think is a reasonable thing. There are doctors around the world who have limited their practice and their research interests to CLL. And for patients that are, have strange forms of CLL, it might be very worthwhile to get an opinion from such a person. Obviously, is somebody who is a general oncologist, can care for you if you have, CLL and you're perfectly fine. All you've got is a perturbed blood count, but you otherwise feel well. If you happen to be sick from your CLL and you're facing therapy, and you may have questions about what therapy should be chosen for that, for the treatment of the disease, then it might be worthwhile consulting somebody who has published extensively in the area and has a specific interest in seeing patients with CLL. So
Actually,
maybe just, and the other thing about, is somebody better than another? We really don't think about it so much that way. We think about, if I have a question, who would I ask? And then, a lot of the times, this is kind of what we do. We ask the questions and the answer is, boy, that's rather unusual. And there isn't really an answer, but it's just nice to bounce it off somebody else. And oftentimes we'll send patients to places and have them see somebody else just to see if we've, if they think differently, if we've missed something.
Okay, Dr. Lister, there's one more question. I recently learned that animals can also have CLL. Is there any need for study participants like dogs? Not sure.
So if you're in veterinary medicine, yes, you probably want to do that. I am not familiar with the actual biology of CLL in dogs. As they are mammals, they may share a lot of the same cellular machinery with us. In fact, more than 95% of the cellular machinery would be the same. And it is perhaps possible that the dogs could benefit from the medications that we have, but that would have to be tested in the same fashion that it's tested in humans, so that you could assure that it's safe and effective.
Well, we greatly appreciate this, Dr. Lister, and these follow-up conversations and questions. We'd like to thank all of you for attending our Head of Cancer Lecture Series event. Please continue to join us monthly as we move forward to talk about cancer screening, detection, treatment, and survivorship. As a reminder, tonight's lecture was recorded, and if you're interested in rewatching the lecture, check back on the AHN YouTube channel, which is www.youtube.com/Allegheny Health Network for the full recording. This video, as well as other past lectures, will be posted under the Ahead of Cancer playlist. If you would like to schedule an appointment or have questions regarding a potential cancer concern, please call the Hope Line at 412-578-6473 to schedule. You may also call our 24-hour Nurse for You line at 412-687-4968. Thank you again for attending.
Thank you.
Thank you, Dr. Lister.